Welcome everyone, welcome to this evening's session on leading innovation for patients with valvular heart disease. In this session, here are the objectives. We are going to focus on the lifetime management of patients with valvular heart disease. We're going to discuss the latest clinical data on some of our transcatheter valvular technologies. And finally, we're going to appreciate the value of a portfolio of devices to treat a wide range of anatomy. My name is Sam Dawkins. I'm an interventional cardiologist from the UK. I'm delighted to be joined by an excellent panel and faculty. We have Nicolas van Meekum, who is moderating the first part, Radoslaw Palmer moderating the second part. Volker Rudolph sadly is stuck on a plane, but hopefully he'll join us at some point. We have Philip Bartko, Francesco Saia, Giuseppe Tarantini, and John Webb. And Jan Martins is our medical coordinator with the live site. We'll be joining our friends at St Thomas's a little bit later for an interesting live case. And here's a breakdown of the session. So we're going to spend the first half focusing on mitral and tricuspid regurgitation, looking at currently available devices and investigational devices. And then we'll switch to a TAVI session, and we have a really interesting live case to look at a little later. This session is sponsored by Edwards Life Sciences. We'll be covering much of their portfolio of technology, which spans from annuloplasty to edge-to-edge repair to valve replacement, and we'll also be looking to the future. So I will hand over to Nicolas to talk through some of the interaction that we have planned.
Thank you very much, Sam. So we are well into the first day of London Valves 2024. We are all familiar with the interactive format of these sessions. So please feel free to use the chat. If you have questions, pull them over, and then Radoslav and myself, we can then transfer it back to the panelists, and we can discuss further. Also, we will have poll questions, so please also answer the poll questions. That also helps us to spur some discussion here. So without further ado, it is my great pleasure to invite Dr. Philip Bartko to discuss the portfolio of options we have these days to treat tricuspid and mitral regurgitation, and he's doing that through a case presentation. Philippe.
Thank you very much for the introduction. These are my conflicts of interest. I will start with presenting a patient. She is 80-year-old and has severe symptoms. She's in New York Heart Association Class 3, marked leg edema, despite optimal medical treatment. On transthoracic echo, we can appreciate that she has torrential TR and moderate to severe MR. Her Euro score would be around 6% for 2 procedures and her TRI score 8%. In the transthoracic echo, we see preserved LV function, torrential TR, preserved RV function with tissue Doppler of 0.13. And invasive hemodynamics shows mild post-capillary hypertension with a pulmonary artery pressure mean of 27 millimeter mercury, a wedge pressure of 20, and pulmonary vascular resistance of 2.1 Wood units. On TOE evaluation, the mitral valve shows prolapse of the posterior wall, a indentation in the central part of the posterior leaflet, and mainly centromedial prolapse of the posterior leaflet. Torrential TR was seen also on tricuspid evaluation. She has 3 leaflet configuration, but there is also very dense caudal, subcaudal structures. And also there is posterior septal jets and anterior posterior jets. So there was recently published the GLIDE score, which shows the probability of successful repair of a TAVI procedure. And we can see that this patient has a posterior septal, anterior septal jet location, high caudal density, and a complex jet. So the GLIDE score in these patients would be around 2 to 3, which means that the patient has only 50% probability of a successful tricuspid TAVI procedure. And with that, I'm giving back to Nicolas for the poll.
Yeah, so let's go to our first poll question then. In an ideal world, so in this patient with severe primary MR and concomitant secondary torrential TR, how would you want to treat this patient? So we have all the options there, so please, what would be your selection? either treat everything with TEER, everything first, or we first go for the mitral and then wait and see what's happening with the tricuspid regurgitation, or consider a TTVR first, or consider a TMVR first. It's multiple options. So what would be your preference? Well, clearly, it's a wait-and-see approach for the TR and first address the primary MR. I must say that in my practice, that would be the same strategy. Philippe, how are you moving forward?
So thank you very much. We did a different approach in this case, and I will show you during the session how it ended up. Maybe I can just continue with showing the data for the TRISCEND-2 trial. Because this patient was a complex patient and we decided to go for tricuspid valve replacement. This was a randomized trial of the EVOQUE transcatheter tricuspid valve system just published this year. It is a device that is a self-expanding frame of a 19-hole frame. It's delivered via the transfemoral approach by 28 French delivery systems. It had 3 sizes formerly, now it are 4 sizes. It was just CE marked the largest valve size with 56 millimeters. The TRISCEND-2 study evaluated the safety and effectiveness of the EVOQUE valve system compared on top of medical therapy compared to optimal medical therapy alone, and randomized in a 2-to-1 fashion to TTVR and control, and had a composite endpoint after 1 year, which was a hierarchical composite endpoint for safety and effectiveness. The patient's cohort was an elderly patient, mainly female with about 75%, highly symptomatic, and the patients also had, most of them, atrial fibrillation and high surgical risk. Remarkable was also that the patients had in more than 50% massive or torrential tricuspid regurgitation. And this was the safety outcome, which is here sorted according to early and late events. And we can see that in the 30 days post-procedural, there was a cardiovascular mortality of 3.1% versus 0% in the control group. Severe bleeding was observed in 10% of the patients receiving the therapy, and 24% in pacemaker-naive patients had to receive a pacemaker implant. But this evened out in the late events from day 30 to 1 year, with 5.7% cardiovascular mortality in the device group versus 7.8% in the control group. Severe bleeding was not different, with 5 versus 4%, and also pacemaker rate was same in the late phase. The primary safety and effectiveness endpoint was assessed by the win ratio, which proved a hierarchical endpoint, composite endpoint of all-cause mortality, need for RVAD implantation, tricuspid valve intervention, annualized rate of heart failure hospitalization, KCCQ improvement, New York Heart Association class improvement, and improvement in 6-minute walk test distance. And it was highly significant with a win ratio of 2, but this was mainly based on improvements in quality of life and symptoms. Regarding mortality, we can see that there was no statistically significant difference between the device group and the optimal medical therapy group. There was a slight increase in mortality in the beginning of the study assignable to the procedure, but in the later phase of the study we can see a crossing of the curves. But this didn't reach any significance. Also, if we look at the landmark analysis, which started 1 month, there was a numerically better, lower mortality in the TTVR group, but also this did not reach statistical significance. Very remarkable with this therapy is that it was possible to reduce tricuspid regurgitation massively in all the patients in the device group with 95% less or equal than a mild tricuspid regurgitation. Also, there was a massive gain in quality of life and symptoms, and also a slight gain in the 6-minute walk distance. So I'm coming back to our case now. We also screened the patient because we saw the tricuspid as the main problem of this patient, and we screened for the EVOQUE system, and we did a CT scan and saw that the valve annular perimeter derived diameter was 45.7 in diastole, which showed that the 48 millimeter valve fits for this patient with an estimated oversizing of 5%. In the RV spin, we can see that tricuspid billowing of the leaflets, which also speaks for maybe a primary component in this patient, and there is enough room between the papillary muscle tips and the valve to develop the valve. Here is the intraprocedural images. The ventricular side of the valve is already developed, and on the MPR spin on the right side, we appreciated that all the leaflets were in a capture-ready position. So we proceeded and were able to deliver the valve. And can show that there was only trace or no tricuspid regurgitation after implanting the valve. One thing that was striking was that mitral regurgitation was increasing, probably due to improvement in cardiac output after implanting the tricuspid valve. So no low flow situation anymore. That's a normal flow situation, and there was an increase in mitral regurgitation. Coming back to the CLASP IID trials. We just heard it in the previous session. It was a randomized trial to compare the Pascal system with the competitor system, the MitraClip system, and the Pascal system is a nitinol-based system which has two sizes, the Pascal P10 and the Pascal ACE system. It has a central spacer and it's capable of independent leaflet grasping, and the CLASP IID trial included patients with degenerative MR and randomized in a 2-to-1 fashion to the Pascal system or the MitraClip system. And the results were that the systems were equally, so there were no inferiority of the Pascal system, and 95% of the patient had, after the treatment, 2+ or less mitral regurgitation. But there was also a second arm in this study, which was the CLASP IID registry, and this registry included patients with a more complex anatomy, which were ineligible for the randomization. So patients with more than 2 jets, bileaflet multiscalar prolapse, flail leaflet with a large flail width or a large flail gap, significant jets in the commissure area. And it also showed that it is feasible to reduce mitral regurgitation in these more complex anatomies sustainably throughout 2 years. So we're moving on with the case. Looking again at the mitral valve, we saw that the central medial prolapse there was a slight indentation in the central part. But we aimed for the central medial prolapse, and we see the clasp on the right side, which was possible to simultaneously clasp both leaflets and then deliver the device and straighten out the prolapse, so anatomically a success, and then also marked reduction in mitral regurgitation. After 6 months, we have seen the patient again. This was one of the first cases we did in Vienna with EVOQUE and as a combined procedure. And we saw that the patient had a significant gain of quality of life. She came back with much improved symptoms. The primary care physician stopped diuretics. She still had no leg edema despite stopping diuretics, and she had normal valve function with only trace tricuspid regurgitation, a mean gradient of 2 mm mercury, mild MR, and there was a mild impact on the EKG with a right bundle branch block after the procedure with only 120 milliseconds, which remained stable, and there was no need for a pacemaker implantation. So taken together, patients with significant MR and TR may benefit from a staged or concomitant intervention, concomitant TTVR with the EVOQUE system and mitral tear with Pascal precision system was in this case a feasible option and an effective way to treat this patient. Thank you very much.
So Philip, what was the interval between the two procedures?
It was in one procedure. So we did it in one procedure, yes.
And how long did it take you to do the procedure?
Well, I mean, it was one of the first cases we did with EVOQUE, so I think roughly 2.5, 3 hours, something like this.
Okay. So because you were doing it in one session, that would change a little bit the approach. But if you would not do it in one procedure and you have to do it as a staged procedure, would you then still consider doing the TTVR first?
Well, that's a very good question. I think so, because I don't see that the mitral regurgitation is the main culprit in this patient.
Okay, so I have a different opinion, and I would like to know what the current and the former president of the GC think about that. Would you consider treating the tricuspid valve first, so eliminating the torrential TR first, in a patient who has moderate to severe MR?
Well, Nicolas, I think that the focusing on clinical aspect of the patient is very important. So in this case, you have anatomically, they consider to be, and it was like that, organic both valves. So primary, so they had to think about treatment of both. And from the echocardiographic standpoint, tricuspid was more severe, was more relevant, and clinically it was more relevant. So I think that this could be a very good option.
Well, I respectfully disagree with that. I don't think it was more relevant, because it was the mitral regurgitation was underestimated because of the issue on the right side. So, and I think you can anticipate that if you you eliminate the TR, you will disclose severe mitral regurgitation. Giuseppe.
Actually, what I think is that the mitral regurgitation was a primary and degenerative disease, and actually there was also pulmonary hypertension. So in my practice, I used to treat first the mitral, in this case, because we have an underfilling because of the tricuspid regurgitation. You cannot apply even the, if you want to apply, let's say, thermodilution, you cannot do that because of tricuspid regurgitation. So for me, mitral is first. Then I will stage the treatment of tricuspid after the reduction of pulmonary hypertension. I will reevaluate it because we are not surgeon. We have time, and actually we can stage a procedure. This is my...
I think that's also a very elegant approach, because if you would do it the other way around, you would first treat the TTVR, and then you would wait, for instance, 3 months. Then obviously you expose the patient to heart failure hospitalizations because you already have pulmonary hypertension. John, do you have any comments on the sequence of the treatment here?
Which is mitral, which is tricuspid?
No. It was a TTVR.
No, I'm just kidding. So, well, I think I picked your side. I think I went mitral first, but I don't think there's a right answer here, and obviously it's worked out very well.
Of course. No, and it turned out very well, right? But I think in how many geographies will we be able to do this procedure as a one-stop shop? I'm not so sure. It's at least in my center.
I mean, I think it's also important to appreciate that if you address the mitral first, and then you do the tricuspid, there might be an increase of your residual MR in your result. So if you So you can treat probably the mitral maybe a little bit more accurate if you have addressed the tricuspid. And on the other hand, there is also, I think, a positive aspect of the way to treat the patient this way is that if you do the mitral first, you release the strain on the right ventricle a little bit more if you do it in one procedure. You don't need to wait and
Nicholas.
I think this is such an interesting case with a great result, and I think we don't really know how to treat multi-valve disease. We all have our views on it, but we don't really know, and we face it all the time. It makes sense that if there's one lesion that's more severe and primary, and another lesion that's less severe and secondary, to treat the primary lesion first. That makes sense. A consideration, I suppose, in this case you used edge-to-edge repair, so not such a consideration, but if you're going to replace the mitral, that would make the tricuspid procedure much harder because of the imaging from shadowing from the device, so that's a consideration. I mean, I have to say, I'm gonna vote with you. I think I might have treated the tricuspid first here, because it was clearly the dominant pathology, and there was a primary component to it as well.
And then you would readmit the patient in heart failure and then treat the mitral.
So the concomitant thing is another interesting question, isn't it? And that's very, very constrained by funding. In our healthcare system, actually, there's no penalty to doing concomitant procedures.
But, Nicholas, but I think that it makes a huge difference if you have two functional diseases or two organic disease. I mean, I totally agree in treating mitral first in functional. We know that in 30% of the cases, the tricuspid will then improve, and probably it will not need treatment afterwards, despite the fact that if it stays severe, then you should treat that as well. But if both are organic, in a case like this, I don't think it really makes a difference what to treat first.
Yeah, I think a beautiful case presentation, thought-provoking, and this was mission accomplished. So let's move on to the second chapter of our session today.
So I would like to ask our friend, Professor Francesco Saia from Bologna, to present his view on the future of lifetime management in these patients.
Thank you very much, Radek. Good afternoon, everybody. Dear colleagues, in the next few minutes, I will just point out a few concepts that are relevant to the topic of this symposium. So the first very basic concept is that when we are treating different patients, of course, we have different therapeutic objectives. And thanks to the results of the low-risk trials, nowadays we are focusing more and more and treating more and more on younger and lower-risk patients. Indeed, if we look at adoption of TAVI in Europe is now the first technique, the first therapy to treat patients with aortic stenosis. And if we look overseas, we can see that in the US, 90% of the patients between 65 and 80 years are treated with TAVI, and 1 out of 2 patients, even below 65 years old of age, are treated with TAVI. So our therapeutic horizon has moved from the 5 years that we had in old and high-risk patients to the 15 years on average that we have as an horizon in patients between 70 and 75 years of age. So when we deal with such a long term, so we talk about lifetime management, and 3 are the main factors that we need to take into consideration: safety and efficacy of the first procedure, durability, repeatability. We cannot accept suboptimal procedural results, and we must have procedures with a very low incidence of complications, including stroke, major vascular complications, need for permanent pacemaker, and paravalvular leak. But we cannot even avoid to think about other factors, such as the potential to recannulate the coronary. And I'm particularly happy to share with you the results of the GISE caveat registry, showing that up to 40 to 50% of the patients receiving tall frame self-expanding valves may have some issue in recannulated coronary in terms of difficult or unfeasible access. And this compares not favorably with the balloon expandable short frame Sapien 3 family, in which 90% of the cases both coronaries can be cannulated. The second factor that we need to take into consideration for lifetime management is durability of the valve. And now we have a wealth of data, both from clinical trials up to 5 years and from clinical registries up to 10 years, showing that there is no significant difference between transcatheter and surgical bioprosthesis in terms of structural valve degeneration and or bioprosthetic valve failure. So the results are very good nowadays already for transcatheter options. But future direction we can further improve, and by addressing something that pertains to leaflet tissue engineering, optimization of the THV stent design, procedural optimization, and as an hypothesis, maybe also some improvements in pharmacotherapy. Staying on the leaflets, in the bioprosthetic leaflet technology now, it's very interesting the progress with the Resilia tissue that incorporates an advanced calcium blocking technology. This has been applied to surgical prosthesis already for some years with excellent clinical results, both short and long term, and more recently to the Sapien 3 Ultra Resilial valve, which may have also an additional advantage of some improved hemodynamics thanks to some tiny changes in the way the leaflets are sutured to the metallic frame. The third factor, relatively new concept, is the concept of repeatability of the first procedure. So most of young and low-risk patients will survive the generation of their valve. So we need to think about the second procedure. And if the first procedure is surgical, then we know that the second procedure can be valve-in-valve or reduced surgical procedure, but valve-in-valve TAVI has better procedural outcomes, it's safer, and is by far the most preferred option by the patients. So probably this will be the second procedure in most of the cases. Although there are some issues that we have to consider is the risk of prosthesis patient mismatch and coronary compromise or compromise of coronary access. We have some solutions for that, but we have to think about that. This may tilt our decision toward the reduced surgery in some cases. If the first procedure is TAVI, then the redo is, in most of the cases, will be a second TAVI, THV-in-THV. This is because we know that TAVR explantation has a very high risk of mortality and morbidity, both at short and at long term. So redo TAVI is the main option for these patients. But we cannot avoid to think about the complexity of redo TAVI. It's not so easy as a procedure. We need to familiarize with the new concepts like the risk plane, neoskirt height, leaflet overhang, the metrics of the first valve, and we have to put this into the anatomy of the patients to evaluate the feasibility and safety of a second procedure. We need to consider if the valve is tall frame, short frame, intraannular, supraannular leaflets. We need to consider the width of the sinus of Valsalva and the STJ, because this may compromise coronary in the event of a TAVI-in-TAVI procedure. And we must be very familiar with this concept. And I will close with just an example. This is a patient, 73 years old, low-risk patients. He was treated with tall frame self-expanding valve. A suboptimal procedure results was accepted in terms of asymmetric valve expansion, residual aortic regurgitation, and also there was an important misalignment of the valve with an overlap of the post of the valve with the left main ostium. In addition, there was a very narrow STJ and the valve to aortic distance was below 1 millimeter because of the very small aortic root annulus. This patient had a balloon valve failure at 4 years with severe aortic regurgitation, and you may easily understand how retreating this patient with a THV-in-THV can be either not feasible from a safety standpoint or very high risk. So in conclusion, ladies and gentlemen, I think that when we think about lifetime management, we must say that with great power comes great responsibility. So we need to do the best choice from the very first procedure, taking into consideration surgical risk of the patient, life expectancy, but also the techniques and the devices that we have in our hands. But we cannot avoid to think that the future of our patients starts today, so we need to think from the very first moment to the possibility that young and lower risk patients have a second and maybe sometimes even a third procedure. Thank you very much.
Thank you so much, Francesco, underlining that the choice of the first treatment actually defines the whole lifetime of our patients. And the concept of TAVI repeatability, I heard, Giuseppe, from you first. How would you think which patients would benefit from the focus on TAVI repeatability most and as a lifetime strategy?
So actually, for sure, the patients with longer life expectancy, that is the patient that is younger, but also at low surgical risk. Because if the patient has an intermediate to high surgical risk, the life expectancy after in surgical series is pretty much lower and comparable to patients older than 75 years old. So actually, when we deal with younger patients, say less than 75 years old, we need to think the whole sequence in these patients. Mostly, when we deal with the anatomical situation when we have a small aortic annulus and small ascending aorta. This is a very critical situation because when you go with the wrist plane above of the coronary, so the second valve may increase significantly the risk of creating a graft tube, a neoskirt, that goes there and creates a sinus sequestration. See, this is what I think related to the life expectancy. On the contrary, when you have a very wide ascending aorta, the problem are really minimized because you can cannulate the coronary artery from outside of the frame.
Thank you so much, Giuseppe. I would like to now to turn your attention and to bring you to St. Thomas Hospital, where Professor Simon Redwood and Tiffany Patterson has prepared a patient, which we discussed thoroughly with the heart teams for the past week. And I'm going to show you and present you the patient to you. This is a 40-year-old patient who was admitted to the hospital with symptoms of heart failure and who already underwent TAVI in 2023 with partial symptoms of improvement post-TAVI. The TAVI device selected for this patient at that time was Evolut 34 millimeters. And the patient was treated for the pure aortic regurgitation more than 1 year ago. With the patient, comorbidities included end-stage renal disease with a previous transplant. Also, the patient had received the CRT defibrillator implantation, the atrial fibrillation, and also the acquired thrombocytopenia were the risk factors for this procedure. Here you can see the summary of these cardiovascular factors with renal disease, AF, and lobus. Also, the BMI of this patient was, as you can see, 17.5. So the patient is very fragile, is independent, and with reduced mobility due to arthritis. This is the medical therapy which was initiated in these patients. This patient is also on NOAC anticoagulation because of AF. The hemoglobin level and troponin and renal function, as you can see here, this patient requires chronic dialysis. This is the ECG showing the pacemaker dependence in this patient, and the echocardiography showed severely dilated left ventricle with a lowered ejection fraction to 25%, and severe paravalvular aortic regurgitation, which is shown here at 12 and 6 o'clock position. This is so the CT scan pre-TAVI showed that the annulus, initial annulus size was 586 millimeters square. The STJ was larger than 29 millimeters, and the SOV was 35 millimeters. For the comparison to the CT post-TAVI, you can see that the inflow of the valve the area was larger than 700 millimeters square with a mean diameter of 28, while the annulus the area was 441 millimeters square with the average diameter of 25. You can also see that at the waist part of the evolute, the waist was narrowed to 21.7 millimeters with the area of 374 millimeters square, and also on the panel right lower panel, you can see that this implant was really deep with an implant depth of 22 millimeters. The femoral access in this young patient was good and optimal for reintervention, transcatheter reintervention from the right groin. The patient risk assessment was set as the Euro score of 3.3% and the SDS score similar 3.6% for the discussion of surgical reintervention. We've been discussing this patient for the previous week. The heart team decision was that this patient is high risk for open heart surgery, and the team decided to follow with a TAVI-in-TAVI with a procedure using a SAPIEN 3 Ultra Resilia of the size of the 29 millimeters to treat the paravalvular leaks around this evolute 34 implant. So the key clinical data in this patient is that there is a 42-year-old male who is independent with heart failure symptoms prior TAVI using evolute R34, severe paravalvular leaks around the procedures, and severe LV dysfunction. With this, thanking you for this, I would like now to ask Sam Dawkins if you can present the strategy which we discussed for safe and effective treatment in this patient.
Thanks very much. So the objectives of this live case are we are going to go through the key steps for transfemoral TAVI, streamlining the TAVI procedure, and demonstrating some of the challenges of TAVI-in-TAVI. The strategy here is a procedure with local anesthesia and conscious sedation. They are going to use a right transfemoral approach. We will talk about the reference markers for valve deployment and confirming the appropriate height. And they are planning ultrasound-guided access, pre-closure with a ProGlide device, a 16 French sheath, a 29mm SAPIEN 3 Ultra Resilia. They'll be deploying with rapid pacing and closing in the usual way. Our operators are Simon Redwood and Tiffany Patterson, and I gather they are ready to join us around about now.
So we would like now to move on to St. Thomas Hospital, and we hope we will be ready to connect. Hi, Simon. Hi, Tiffany. We can see you and we can hear you.
Great. Hi. So we've been ready for hours, actually. You can see we're just sitting here waiting. My name's Simon Redwood. I've got Tiffany Patterson, who's first operator doing this case. We've got Seb Baxter, who's doing the GA, and I'll explain that reason in a minute. And Corinne is going to be showing us some nice TU images. Fortune is our radiographer. We've got, forgotten your name. We've got Claire and Mary doing the nurses. I know, and Jess. Only joking. let me just explain what we've done. So we had planned on this being a local anesthetic, standard sort of TAVI, or TAVI-in-TAVI procedure. But the poor chap's got avascular necrosis of his hip and was in a lot of pain lying on the table and couldn't really keep still. So we thought it was kinder to convert to GA for that reason. And because we converted to GA, we thought it'd be quite useful to have TOE just to give us some extra guidance and have a look at this paravalvular leak. So it's now a general anesthetic procedure. In terms of access, we've got an arterial sheath, 6 French on the left. These are all ultrasound guided micropunctures. We've got a venous sheath on the right, which has been given to Seb for the purposes of giving anesthetic drugs, because he's got a fistula in his right arm, and access is not very easy. And then we've got the 16 French E sheath in the right femoral artery. And I don't know how much time you had to look at the CT, but if you look at his actual annulus, his right coronary comes off quite high. It's about 15 millimeters, but because this is an EVOQUE valve and it's supraannular, we're worried that the right coronary is going to be covered by the EVOQUE leaflets when we deploy another valve. So we've elected to protect the right coronary. So that's the reason for the left femoral sheath. So we've got a standard 6 French Judkins guide. We've put a wire down the right coronary, and we've got a guide liner, which we put into the coronary, and then we had a 4 or 5 Megatron stent, which is ready to be deployed if needs be. We've actually crossed the valve. We've done some aortograms, we'll show you all this in a minute. And we've crossed the valve, and we've got a pigtail in the LV. So if we go to the image number 3, please. So this is an LAO caudal aortogram. And I think you can hopefully quite clearly see his own annulus there, his native annulus, and the depth of the evolute, which has dropped down post-deployment. And you can see the right coronary there coming off. And then the next one is view 5. And there you should be able to see the right coronary. So that's the situation we're in now. Because we had a pigtail in the LV, we've actually measured his EDP, and we can show you that now. If you could show that snapshot of the hemo screen. So that shows there's no systolic gradient, and in the next picture that showed it in high speed, you had one there, that's the one. So you can see there the EDP is actually about between 28 and 30. So he's got a high EDP. He's got quite barked paravalvular aortic regurgitation. There's no systolic gradient. And that's the situation we're in now. Now, before we stop talking, should we just turn to Corinne so she can show you some TOE images of the leak? Corinne?
Yep. Thank you very much. So I have some long axis view of the TAVI valve, and we can see the color flow of the paravalvular leak going posteriorly under the anterior mitral valve leaflet, and it's quite significant jet. And if we look from short axis and face view, we can see this posterior paravalvular jet outside the stent of the valve. The valve itself is well expanded, so it's somewhere between 12 to 2 o'clock. Some 3D images which also show that nicely, this severe paravalvular leak going. This is anterior mitral valve leaflet, so even impinging the opening of the anterior mitral valve leaflet.
Very nice picture.
Thank you.
Okay, so before we move on, do you have any comments or questions?
Yes. So,
Is this working? Do I need a...
yeah.
So on the aortogram, it looks like this valve is way, way low. And
Yeah, it is.
the leaflets on the aortogram appear to be well below the right coronary ostium. So I guess my first question is, I don't think there's really any danger of obstructing the right coronary because the evolute leaflets are so low.
No, in fact, that was our initial thought as well, and I think that's a fair point. I mean, the contra to that is that he's only in his early 40s. He's got poor LV function. If we did occlude the right coronary, I suspect it would be a catastrophic event. And we want to give him his best chance because he's had this evolute which hasn't really worked and hasn't really helped him. But we take that point.
Can I say something also? Hi, Giuseppe Tarantini speaking. So another challenge in this case is that this valve is 34 in the inflow, but the level of the waste by metric is 24. So actually there is a difference of 1 centimeter. It's one of a kind in this regard, because with all the other core valve is different, is below 6 or below 5. So the point is that considering that the 34 is within the ventricle, and actually the landing zone is above, and the risk is going with a 29, you might have a push down because of the shoulder of the balloon. Have you considered any strategy to avoid that? What is your idea?
We've talked about this a lot, and I'll let Tiffany give you her views as well, but it's going to be, we're going to be having quite a high deployment, and the top of the SAPIEN is going to be hopefully at the top of that waist. So just below where you see now that stent in the right coronary.
Just show the
If
LV
that makes
apex.
sense.
Yeah, that's our main concern here, is the melon seeding into the ventricle, into the
worried about that.
LVOT. That's going to be the biggest issue. So we've got a second valve on standby, should that happen.
Anyway, I think it's important to state that 29 is the right valve, because the 24 waist can be expanded plus 2. Is going to get 26. So actually 26 is a small valve. So 29 I think is the right valve.
It is for this annulus.
So what is your plan for positioning the SAPIEN? Will you position it against the core valve nodes, or are you just going to position it against the annulus, way high up?
So, and that's another good question, because we actually changed our view. We were originally going to position it quite low and try and get the outflow of that paravalvular leak, so quite near the lower end of the EVOQUE valve, and perhaps end up being node 4 or 5.
I would be tempted to ignore the EVOQUE and just pretend you're doing a SAPIEN implant in the annulus.
Yeah, that's exactly what we're going to do. That's what we've decided, and that's one of the reasons, or another reason for having TOE, but also, we've got that right coronary catheter there, which actually fills the native sinuses very well. So that's exactly what we're going to do. So it's going to appear to be a very high implant, but that's because the EVOQUE is very low.
But that's that's an additional landmark that you have now, right? That's the catheter in the RCA. So it's very easy to position the aortic part of the frame right below that right coronary catheter, and I think you'll be okay. Because you don't want to implant the SAPIEN valve too deep here, and sometimes, at least I find these nodes difficult to appreciate as you are implanting. So
I would just ignore that.
Me too.
This is what we've decided to do after lots of discussion.
Also, traction, please. More traction. Get the whole system straight. I'm sorry. Thanks.
One of the reasons to bring the SAPIEN valve higher may also be that if the waist is going to shape the SAPIEN frame, then it's much better that it shapes the inflow of the valve impinging on the skirt rather than on the outflow of the frame, then deflecting the frame inwards and increasing the pinwheeling and impacting the opening of the leaflets.
Just wait 1 second. We just need to get it past this calcium. I need some track. Just pull the wire.
Yeah.
No, I'll come back. Just pull the wire now. Let me just put some flexion on.
Yeah. So we've got a porcelain aorta. I don't know how well that projects.
Okay, just hold the wire for me.
There we go.
Projects very well, Simon.
Getting caught
we
all
can
the way.
certainly see that.
I mean, we were even having trouble getting a standard floppy J wire up.
Okay,
So it was catching on all this calcium. So it's remarkable that we got to this stage.
Just feed the wire so it's in the distal LV before we go around.
So I don't know if you just saw that. We just had to do a bit of wire manipulation and a bit of flex to get that past that.
Yeah, there was a lip there, wasn't there? But nicely crossed.
Okay, so we just need to keep an eye on everything. So can we open up our cones? Thanks. Yeah, that's great. And just table away from us a tiny bit so we can just see the whole picture. That's great. Thank you.
We need to see the arch a bit more, please. That's it.
So just pull on the wire a little bit for me, Simon.
Yeah.
We can see how
I'm going to release flex and come back. Feed the wire. Okay, I'm going to go straight there. No? Okay.
So the challenge here is the porcelain aorta, isn't it? It's obviously very irregular, and although this man is 42,
pull on
he's
the wire
got
for me,
end-stage
Simon.
renal failure and is biologically considerably older. I don't think. I mean, that's a spectacularly porcelain aorta, isn't it? I mean, that's really, really difficult for anatomy. And so Tiffany and Simon are just working out how to make the interaction with the wire and the flex just to disengage from that lip of calcium they're catching on.
More LAO, please. No, just wait. I can see what I'm turning into. More LAO. Yeah.
But a case like this, you just need to take your time, don't you? It's about taking your time, maximizing the imaging.
Sometimes, if it is stuck, you can try to disconnect the valve here, like in the pulmonary valve.
It's a good idea. Yeah. So just give me some traction.
Do you think it's the pusher that's getting caught? Right. Not the valve.
No, I'm going to come back. Okay, so let's try a bit of rotation. Let's go this way at the outer curve. Let me try that.
Yeah.
Yeah.
That's it.
Now it proceeded. So we could see two maneuvers you did. First, a more LAO, just to appreciate the aortic arch and also
traction,
the pulling and the traction on the wire.
Pull.
That's it.
And then I need to pull again.
Yeah.
Pull. Okay, we need to just rotate this.
So
Okay. Yeah.
That's it.
Okay.
Nicely done.
And now we can also see the benefit of the deflector.
Yeah. But it was more than just deflecting, it was turning the whole catheter
So ease back
both
up.
anti-clockwise and clockwise.
Okay. So we'll have a bit of contrast there, shall we?
Well done.
And should we go back to our view? Unfortunately, we couldn't put a sentinel in this gentleman because he's got an AV fistula in his right arm for dialysis. Otherwise, we'd have liked to have done it with all this calcium and crud. Okay.
Picture.
Can't see it as clearly there, can we? But if we just look at the previous picture, we can just check where we want to align the
We've got it, yeah.
top. Just play that back. Yeah, any of those pictures is good with some dye. So let's just go to number 5. Number 5. So
we really want the top of the
80-20.
sapien just at the bottom of that catheter, don't we?
Yeah. So you want to get rid of
think?
the parallax of that evolute valve, and then I think position the aortic part.
Yeah, the trouble is if we get rid of the parallax of the evolute, then we get a bit of parallax on the
on
annulus.
the valve, yeah.
And I think it's the native annulus that we're more concerned about. So this view that we've selected is very similar to the original CT-derived view from.
I'm thinking probably here. I think, in fact, that actually looks too low to me. I'm worried that might melon seed.
Yeah.
But why don't we take the
about
parallax off the evolute and then come back to this view?
I think this is good because it's going to shorten more from the ventricle and it's going to end up right in the middle of that waist.
It's not going to happen. It's not going to foreshorten from the ventricle because you have that other frame that prevents it from foreshortening.
Yeah.
So
Okay. So we're across the valve. We need to bring the pusher back.
when there's severe AI, you can't count on there being so much shortening up.
Maybe we do a 10 mil because we're out of the coronary.
It doesn't quite interact the same way.
Mils?
No, exactly.
Oh, no, 8 mils,
Exactly.
10 mils, whatever, something.
210. Inject again, Jess. Everything just seems to be sucking down.
Yeah.
I would let's go slowly, Simon. And we'll sort everything else out in a minute.
Happy?
Still goes really slow. Keep it really slow. Keep
Oh,
going.
yeah, it's looking good.
But don't do a sudden
No, I'm not
final.
going to.
Okay.
Yeah, that's good. That's perfect.
Yeah. How's that looking?
It's all in.
Looks good.
Okay. And down. And Just wait, and pacing off now.
I would just like to turn your attention to the points listed in the, where you can have it on the questions. First, starting on the strategy to treat this patient. There are many questions mentioning the paravalvular leak closure as opposition to using the redo TAVI technique. What do you think? What would be your strategy? The panelists, Francesco.
Well, yeah, I did a series of patients of closure of paravalvular leak in TAVI, but this is a complex procedure, and I don't think it's the ideal in a 42-year-old patient. In this case, I mean, TAVI-in-TAVI, it's a complex procedure. We saw this is it's not straightforward. This is a case that I hope will end up happily, but no, for me, THV-in-THV is first option, even in terms of future treatment.
The mechanism here is important, isn't it? Because we think this is because the evolute has slipped, and so therefore there's probably no skirt in contact with the annulus, and it's not touching the sides. And so I don't think, I mean, paravalvular leak closure in TAVI is never easy. It's much easier in surgical valves. And here I think that what we need to do is fully expand the evolute at the annulus and regain contact there. So I don't think a paravalvular leak closure procedure is an option here. And I think this was always going to be extremely complex, this procedure, and I suspect that this patient, this is a very long pacing run, and I expect with a bit of inotropes everything will resolve. But this is a very, very brittle situation in a patient who's in real trouble, and I personally think that a valve-in-valve TAVI is the best way to get out of this particular situation.
Thank you. And Giuseppe, do you believe that predilatation of the evolute R system has any role to soften the tissue and it can facilitate the expansion of the sapien?
I think in this case, I think let's say predilatation is not worth doing, because actually the point of regurgitation here is the malpositioning of the first valve, because it's too deep in the ventricle. The valve is hourglass, so it's flared in the central part, so this is the reason of the mechanism. I fully agree with the comment before. Actually, I think that the cardiac arrest here is related to the pacemaker. Actually, this patient has 25% ejection fraction. Yeah. When you go for prolonged pacing and prolonged inflation, this might be the mechanism, but if this is the mechanism, they will be able to revert the situation, because actually you just need to have an increase of blood pressure. But my answer is no, predilatation in this case is not the way to go.
And Professor Webb, you know this platform best from all of us. Do you believe that overinflation of so putting more volume to the commander system plays any role? Should we use nominal volumes in this patient? Should we overinflate? Should we add volume?
I don't think that you need to overinflate unless the valve is too small. I would actually go back to the CT that was done at the time the evolute went in and size based on that. Mm-hmm. I really do think the evolute is just a little bit irrelevant here. It's slipped into the ventricle and it's too small in the annulus, so a plug isn't going to work. You just need to expand the mid portion of this valve. And I think if I were to take a 29, I probably would actually under deploy it and see how it looks, and then make it bigger until it looked appropriate, because I think we're a little unsure about this. I think the problem was a long period of ischemia.
Yeah.
Yeah.
Do you use double tap technique often for the
implementation? Well, so we just finished a 100-patient study on this, and it's submitted now. And in our study, it seemed to routinely increase symmetrical deployment and in the area with sapien valves. So I think you can make an argument for doing it routinely. Now, we're a little lazy, so we don't do it routinely now we're finished our study. But we do it very commonly. Yeah,
I just mentioned double tap. Can you just explain to the audience what your strategy for double
tap? Well,
the
thinking is that balloon expandable valves are often smaller after you deploy them than you would think they would be. And it's not that the valve recoils, it never fully gets expanded. And with the second inflation, you focus the force on the underexpanded part of the valve and make it larger. And I think we have pretty good evidence that this routinely gets these valves slightly larger, closer to where they should be. And probably results in lower gradients and maybe results in less halts and maybe results in greater durability, although that's speculative. But certainly with double tap, without overfilling the balloon at all, you routinely get slightly larger wastes, up to 1 millimeter, or half routinely, and a more symmetrical appearance of the expansion of the valve.
And, this is an important comment, because actually when we do this procedure, seems to be all about pre-procedure planning, but actually it's not like that, because we need to optimize the implantation, we need to evaluate the result of the implantation with the invasive evaluation of the gradient, and in case post-dilatation. This is, something Jean is very experienced, but actually many times we need to overlook the need to optimize the implantation of the valve, even the balloon expandable valve.
Thank you, Giuseppe. And Francesco, we saw a highly calcified aorta with a difficulty in traction of the device. Would you recommend any techniques to facilitate the crossing in such patients?
Well, I think that they did very well in terms of, you never need to push too hard and take your time and, find slowly, leave the valve slowly, find the way. It's a push and pull that the two operators did very well coordinating themselves. And also at the same time, sometimes, as they did, also turning a little bit the valve just to change the curve. So I think basically this is what I will do. Occasionally I saw, but I never did it because never was needed in my experience, but occasionally I saw also body balloon, sometimes in cases, to help crossing some difficult.
Has dry seal any help in this kind of situation? Like large ball?
Yeah, because there's a 60 centimeter one, isn't there, which can get you past a lot of this anatomy, which can be helpful for passing through EVARs, can be helpful in this kind of situation. But the challenge is predicting it. I mean, obviously this chap has a porcelain aorta, but it's not immediately obvious where it's going to get stuck. So I think we're coming to the end of our time slot now, and we can't overrun, I'm afraid. But the good news is they're making good progress in the cath lab. They have an output back, and they're focusing on getting the patient stable, but everything moving in a positive direction. So let's draw the session to a close. We set out our objectives that we wanted to look at the latest generation of transcatheter heart valves and how we can use them to facilitate lifetime management of our patients. We wanted to look at some of the latest outcome data for the various transcatheter technologies, and we wanted to appreciate a portfolio of options. They're back. Simon and Tiffany, so we can see you again. Welcome back.
We were enjoying hearing your...
We are happy.
Hearing your summary. Just tell you briefly what happened. So, funnily enough, the right coronary did shut. Went into VF. You saw there was CPR for a while. We gave some drugs. We defibrillated. But it was only once we'd stented the right coronary that we actually got pressure back. So the pressure is actually very high now. It's rebounded up to over 200 systolic. Rhythm's back to normal. The valve is in, obviously. We've got no valvular leak. There's a small paravalvular leak. If you could just show the angiogram, the last angiogram we did at that play. So this is still with a wire down. We could do one a little bit lower, couldn't we, if we want to?
Yeah.
We're a bit concerned about post-dilating this anymore because the annulus area was about 530. Native annulus. And I must say, I think that looks pretty good.
Looks excellent, doesn't it?
So, yeah, it's coming down. We've got 220 on this, 200. So, any thoughts?
We think the result seems excellent.
Yeah, the result looks superb.
I think that you need applause.
Yeah, I was going to say, if ever applause was deserved. Very good. Good work. Well, that was an absolute masterpiece. Okay. Well done, Simon. Well done, Tiffany. Well done, the fantastic St. Thomas's team. A really impressive demonstration. Thank you very much.
And thank you to the audience as well. So, wish you a good evening then.
Thank you. John, it's been a pleasure.
Yes.